So, good
It's
evening,
my pleasure
everyone.
to introduce.
Yeah,
Uh,
please.
it's my pleasure to introduce Jayanth Raghothama. He has a bachelor's in computer science and master's in computer science from IIIT Bangalore. And then he worked in a non-profit for a few years, working on problems of data and public policy. And then he went to KTH Sweden, where he's an associate professor working on data science and health. I will stop there and give it to Jayanth to tell the story.
Thanks, Sab, and it's a genuine pleasure to meet everyone and to be giving this talk. As Sab said, I'm Jayanth. I'm at KTH. The official title is Healthcare Logistics. I'm still trying to figure out what it means, but essentially it means we're trying to give people the right care at the right time. Let me start sharing slides. Yes.
Yeah.
Yeah, so Sab already introduced me. I'm from Bangalore. I did a PhD in distributed simulations, and I'm currently working mostly on healthcare data-driven projects. So full credit to my group and my students, all of the following slides. They worked on projects that I lead or co-lead with my colleagues. So today I will briefly talk about 3 different projects that we are working on, and they are sort of examples of these areas, right? So one of them is a fairly standard kind of healthcare project. So we're developing AI models for detection of cancer in primary care, not in hospital settings, but in like general practitioner primary care settings. The second one is we're working on data-driven models for observing logistics and workflow processes in hospitals. And the hospital that I'll be illustrating is the Karolinska University Hospital, one of the largest in Sweden. And it's in the top 7 hospitals / medical universities in the world, top 10, I think. It's the 7th best according to rankings or whatever. And the third one, we're working on sort of improving the underlying data itself in healthcare databases, and I will explain what these mean as we go. And through these sort of topics, I hope to illustrate what a data science project looks like, where the issues tend to be, and I hope to also kind of illustrate where AI could work, where AI doesn't, and we will see. So I would love this to be a discussion. So if you have any questions, please interrupt. So like I said, actually, before we get into this one, let me first set the context a little bit. So Sweden is a small country, 10 million people. It's actually smaller than Bangalore or Hyderabad, but it is fairly large, and 80% of the population live sort of below Stockholm, right? In the geography below Stockholm. Stockholm is a region about 2 million large, but Sweden is split up into 21 different administrative zones called counties or regions, and each region administers their own healthcare. It's not administered nationally. And each region owns its own healthcare data. So just to set the context a little bit. And so one of the first project that I will talk about is on actually CRC. Colorectal cancer is, So colorectal cancer is the 3rd most common and the 2nd leading death of cancer worldwide, right? It is a fairly significant sort of disease, which carries a huge disease burden. And most worryingly, its incidence is increasing in very young people. So people from mid 30s to mid 45 or 50, even the incidence is rising, mostly due to diet and lifestyle changes. But it is also a cancer with highly non-specific symptoms. So the symptoms initially look pretty much like any gastrointestinal disease, right? So it is missed in primary care a lot. So most sort of initial diseases present themselves in primary care. So if you feel sick, you go to your local doctor before that escalates to more serious levels of care in hospitals or other specialized institutes, right? So in primary care, this cancer is missed a lot. So we started focusing on this one and see if we could kind of identify it earlier in the sort of diagnostic chain. Let's, like I said, it's highly non-specific, it's missed a lot, and like early detection could be fairly critical in sort of catching cancers in earlier stages. It could have, as you can imagine, sort of very significant benefits in quality of life. And more importantly, even if we don't have a high degree of certainty in actually diagnosing cancer earlier, it could affect how we screen for this cancer. Right? So right now, screening is based on age, which is a single variable. So if you're above 50 or above 55, you should get screened for this. But because the incidence is actually more worrying in younger populations, we need ways to kind of figure out who to screen for and who not to, because we can't screen everybody above the age of 35, for instance. It's too high a screening burden. So we need methods both for improving diagnostics, but also improving sort of screening programs. And that's what this project is focusing on. Yeah, like I said, we need to do these models. So it's a fairly, if you look at the medical literature, it's a fairly standard sort of pipeline. It's fairly standard methodology. You gather the data, you process the data, you extract relevant features, you develop a model, you evaluate the model, right? And I'll go through each of these stages in a bit more detail. So the data we started collecting from electronic health records, and which includes labs and demographic data as well. We process, clean, identify the cohort, extract relevant variables. We fine-tune those features, cross-validate, develop the model, evaluate the model within modeling methodologies, and we kind of evaluate that also with clinicians, right? So the data set looks like this. Patient records from primary healthcare centers in Stockholm, which covers about 60% of the region's population. So about 80% of all clinics, primary care clinics in Stockholm, have this data, and we collected it from all of them. And the data was collected 1 year prior to CRC diagnosis. So if a patient was diagnosed with colorectal cancer, we collected electronic health record data for 1 year prior to that date, and we matched it with controls. So cases are patient data which have been diagnosed with colorectal cancer, and controls are essentially similar sort of demographic data, but those who have not been diagnosed with colorectal cancer. And this contains demographic characteristics, lifestyle habits, lab results, doctor's notes, and so on, and about 3,000 colorectal cancer patients with nearly 12,000 controls, and those controls are matched by age and gender, right? So if a man aged 55 was diagnosed in a particular sort of locality, and a similar another man who hasn't been diagnosed with that in the same locality, that data was also collected. And this is to ensure like both positive and negative cases in modeling. So the data set took about half a year to 8 months to collect. Some summary statistics. It's fairly even in gender split, so which is useful. And again, you can see like the age split predominantly above 65, but as I said, its incidence is increasing in younger populations. Then we go to sort of feature extraction. And this is where it starts getting fairly, not tricky, but difficult. So as I said, we have structured data, which is demographic data, labs, lab values, diagnosis, vital parameters during visits and so on. But we also have unstructured data, which is mostly text. And that is basically every time you go to a clinician, they write down some history and so on. And if you've gone multiple times, then you have notes for every one of those visits. If a patient was referred to further consultation, we have that as well. And that is called referral notes. And we also have some categorical data, which is ICD-10 codes. So ICD is a standard international classification of diseases, which basically establishes a unified language or nomenclature for diagnostics. So for instance, a heart attack would be some number followed by 3 digits. Urinary tract infection, for instance, is N109, and that is a universal kind of language for expressing diagnosis. These ICD-10 codes go back 5 years before the cancer diagnosis date. So we collect data, cases, controls from public and primary caregivers. Then we split them into structured data, categorical data, ICD-10 codes, and textual data. The structured data is fairly standard. It's fairly easy to model. All you have to do is basically clean them up and basically pipe it into whatever model you want. The categorical data, we converted into embeddings, which is basically sort of taking this string data and converting that into like a vector format. The textual features was hard despite the presence of large language models. And that is mostly, there were 2 issues with that. One, there was no robust LLM or even small language model to extract biomedical data. So no pre-trained model for this, and no training data either for us to train our own models. The other issue, apart from the domain, was the language. Even in English, few good models, and then if you add Swedish on top of that, the performance of these models got worse. Right. So despite that, we basically extracted topics and entities. We did the best we could with lots and lots of experimentation, fine tuning, and so on. We got fairly good accuracies, and I'll go into that. But essentially, these are the features from the 3 different categories of data, and we combine it into one sort of unified structure to model it. Yeah, like I said. So clinical data, clinical notes, referral notes, we combine it. We perform a technique called NER, named entity recognition. We take the top 20 entities, we take the top 20 models, convert those into numerical features, and basically put it into one unified structure. I'll come back to this slide in a bit. And basically, we started developing models. A simple ensemble model, nothing too complicated, split it, perform tenfold cross-validation, hyperparameter tuning, and model evaluation. And this is what the results look like, right? So as you can see, there are different sort of subsets of the data that we tried. So just the numerical features, just the numerical plus entities, with just clinical notes, with just referral notes. So if a patient has been referred to someone else, we included that, combine those, and so on. Numerical plus topic modeling, everything put together. And we got a fairly high accuracy of about 95%. So this is as far as we know, this is the state-of-the-art model for colorectal cancer in primary care. And we very happily took that to clinicians, and the clinical utility was pretty sad. Mostly because the model didn't give clinicians any new information, right? So it is it worked very well for confirming what they already knew. But for patients where they didn't know, or for patients where they were uncertain, the model was not very clinically useful. So what we did was fair enough. So we essentially examined with the clinicians in a fairly rigorous way what were the features that sort of the model is picking up on that you already know, right? So the model is picking up on certain keywords or certain terms which they've used because they already suspect something, right? So for instance, if you've been referred to a colonoscopy, it means that the clinicians already suspect colorectal cancer, which is why they're referring it to you. But that's what the model thinks is a good indicator of colorectal cancer. So it's kind of like a circular problem. So we went back to the data and we removed all records containing all the features that the clinicians flagged as basically having a high suspicion of colorectal cancer. So any data that could, for instance, predict with a high degree of certainty colorectal cancer, we removed that. And then we basically repeated the whole exercise. And that's what this sort of results are. So this is on the reduced dataset. This dataset doesn't contain anything that the clinicians think already indicates a suspicion of colorectal cancer. And as you can see, the accuracy kind of drops fairly well. But for certain things, the precision and recall are fairly high. All right. So from a modeling point of view, this could work. The previous model could work for basically automated suggestions of diagnostics. This reduced dataset model could work for basically picking up on information and signals that clinicians could evaluate. All right. So there is from this point, from establishing the state-of-the-art model, you kind of venture into different sort of clinical workflows or different setups for how to integrate this in a clinical fashion. Right. So that is one sort of research direction or implementation direction that this work could contribute towards. And this is basically sort of highlighting more results. Yeah, we can come back to this in a bit more detail in a bit. Not super interesting. So like I said, this is the explainability, right? So for the reduced data set with ICD-10 codes, these are the kind of features that it's picking up on. And it's picking up on, let's say, this particular topic, anemia, weight, and some history codes, right? So if you've been previously diagnosed with some of these codes, you're more likely to have colorectal cancer. Without ICD-10 codes, again, it's picking up on certain things. Some of them make sense, some of them don't. But basically, abdomen, creatinine, some bleeding, some hypertension, etc., etc. Right? So, and again, there are sort of metrics for how important a particular feature or a keyword in the data is. So, just to recap a little bit, this is a very typical, very standard, very simple model, modeling workflow. But what makes this sort of project a bit different and a bit unique is the highly uncertain setting in which we are trying to apply it, right? So primary care is very variable. Signals are highly uncertain. But this is also where these kinds of models could have the most impact, because this is where you can catch it earlier. Hospitals are already a bit too late, right? So we've implemented this model and it's ready. But one of the most, like I said, one of the biggest limitations was the sort of lack of clinical utility in a fairly robust model, right? Just because a model is fantastic doesn't necessarily mean it's useful. And we are now moving into, we are actually conducting this. Tomorrow will be the last set of doctors who will come to our lab, look at the model in an emulated trial, and sort of give scores on a patient by patient basis, whether or not they agree with the model and whether or not they can sort of understand the model uncertainty and explainability and so on. So we've done trials with over 10, 12 doctors. Tomorrow, the last set will come, and they will, in a simulated environment, they will look at the data, they will look at the model scores, and basically try and see if the model actually makes sense. Both models, the one with the full data set and the one with the reduced data set. So that was this.
Are the doctors anonymous so that they can't see each other?
Yes, and it is sort of, how do I put it? So the evaluation of one doctors will also be looked at by other doctors. So we have inter-rater variability as well, reliability as well. The doctors also don't know which model, which score is coming from which model. So it's a fairly robust sort of methodology for evaluation.
Are they given the same set of models, or you vary the models too?
So what we do is we tell them to look at a patient and they get model scores. They don't know which model scores that is. And then they also look at sort of patients without model scores, and they have the same evaluation criteria for that patient. And everything one doctor does is distributed to other doctors across both these sort of control and model arms. So we have a fair amount of, so we can see whether or not they actually converge on some kind of agreement. So this trial is ongoing. I should have put that methodology as well, but yeah, sorry. Any other questions on this?
You mentioned at one stage that there was the two paths which were emerging, right? One was where the doctors felt it was fairly obvious, and then the other one which had a lower probability or something like that, right?
Yeah.
What is that real distinction between these two?
So one of the things that we have been thinking about is how to integrate this in a clinic, right? I mean, this is done with clinicians and with their expertise. So the model with like the full data set, like up to a year before diagnosis, they felt that this basically only confirms what we already know. So it's good to have that confirmation, right? They don't have to ask a colleague. They have a tool that is telling them, yes, you're right. Your next steps should be blah, 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 right? So that is one sort of direction where it could help clinicians. The one with the sort of reduced data set with more uncertainty, that basically tells them this is somebody interesting because of these reasons, but nothing more than that, right? So there is two ways in which it could help them, but we're not necessarily, neither of them, unfortunately, is sufficient to go forward with like a full sort of control trial to prove this as a medical device. We're trying to collect a lot more data going back years and developing sort of more robust and more comprehensive models. But neither of the evidence, so the evidentiary standard for either of the models to prove it as a medical device is not sufficient. So we have to.
When you talk about input data, right? You said it was collected from different PHCs and others. So is there a uniformity in the kind of people's data which is involved, or is it like people from different age groups and variety of things, or is it there is a uniformity in that data?
So there is a uniformity in the structure, but I mean, we don't have data on ethnicity for one. We only have age and gender. We don't have socioeconomic data. So that could also be a huge sort of differentiator, purely because of lifestyle. So in age and gender, it's fairly consistent. There aren't too many
Okay.
differences. There are differences in like alcohol and tobacco consumption, but that doesn't seem to be a big enough factor in the results to make a difference.
Okay.
So yeah, that's where we are.
Thank you. Yeah, thank you.
So that was a bit more on the clinical side. And now we come to this project, Karolinska University Hospital. They're the ones who give out the medicine Nobel. And it is challenging. So what we wanted to do was we wanted to create like a systemic basis for understanding how a large complex hospital works, because there is no theory or no sort of framework to explain that. This basically to improve not efficiency, but to make it more effective, to improve sort of resource utilization, staffing, improve patient experience while maintaining the same very high standards of patient safety and care quality, right? So we started in 2022, the beginning of 2022, and as you can see, it took about 2 years to extract this data set. And we should probably write it down somewhere, but this was mostly because we were working with managers and clinicians and working with informaticians in the same hospital, and they did not speak the same language at all. So the doctors knew exactly what data was there, and to translate that into, let's say, it's in this column in this database was a pain, to say the least. So mapping that took about a year and a half. Every change led to a new ethical application and approval. And this is managed nationally in Sweden, not institutionally. And finally, we got the data set and performed 2 more extractions. And the data set is one of the largest they've ever given out. It contains everything that happened to every patient in the hospital for a period of 8 years. So it is extensive, to say the least, and it has significant quality issues. I won't get into those details. I'll just get into like what we are trying to do, right?
Yeah,
So,
one question I have, sir.
yeah, please.
Is that you got event log data, as we are also working in process mining? Okay.
Yeah.
So just when eager to know that for this healthcare system, do you have, for process mining, we use event log data, na? So do you have that event log data set also, which you use?
So you can think about it as event logs, even though it's not in like a format of an event log. So we can sort of mine it and process it into event logs, which you can then pipe into like a process mining tool. But it doesn't contain everything that event logs should. And that process of transformation is not easy.
Yeah, that is why I asked.
Yeah.
Because we are also
you're
working.
right. I mean,
yeah. So
Yeah,
okay.
the problem with event log is you're not carrying the semantics of the event along with it. What is that is the most important part in process, right? Every event is a transformation. Okay. So if you don't have what is being transformed, you are living in the dark.
Yeah. So I think I hope that I will take
it.
your address from Sir Sudhir sir, so we can connect in future also. Because we are having a collaboration with RWTH Arkham University, where Professor Ars is our associate. So we are working with him. So it will be good that we can connect later on. We can talk, Jayanth.
Absolutely. We would love to do that. So,
Yeah, thank you.
to continue this one. So this is a very simple data mining project. No fancy models, no machine learning, no AI. And it can lead to some interesting insights. So the first thing we did was we looked at sort of how long a patient stays in the emergency department from the beginning of the data set to the end. The end of our data set is September 2023, right? So as you can see, it's gone up by about an hour and 20 minutes, hour and 10 minutes over the years. So it's in 2015, the average was around 240 minutes, and now it's around 320. Right, and this is regardless if no matter if you remove outliers or something, the numbers change, but not the pattern. All right. So again, this doesn't take, for our data set, it took a fair amount of time to produce because it's so messy, but it's a very simple chart. So the question then becomes, okay, why, what happened? Why did this change? And we have no answers to some of those questions, but I'll just illustrate how we are working through this. So this is average waiting time by triage level. So red is the least, as it should be. Green, or I think this is the blue triage level, which is the highest. So if you come in with a red, you are by law or by guidelines, you have to see a doctor within 20 minutes. For the last least severe category, I think the guidelines state that about 8 hours is sufficient to see a doctor. So, and then we mapped out like between every steps, how long do patients wait, and so on, and then filtered that by, okay, diagnosis, by complaint, by triage level, by arrival level, by ward, by specialty, etc. So we have these sort of patterns and insights for these sort of some key metrics like waiting time or length of stay, and with added filters for most things. Some of them are informative, some of them not so much. You can't really infer a lot from some of these graphs. And again, this is just statistics, and not even statistics, is just pure data mining and visualization. Then we started looking at length of stay. And this is probably full caveat. This is probably not the best indicator of anything, right? But it highlights some interesting patterns. So these are the top 20 ICD codes by diagnosis, by frequency, like the most sort of diagnosed diseases in the hospital. And most of them follow a fairly simple pattern. There is a bulk of patients with an average. But if you look at these sort of this black bars on the right, they're not actually bars. They're all individual patients, which are all outliers. Right? And this was a very surprising to many people insight, because people expected a few, not so many. Right? And the question that then comes up is, okay, how much are these sort of patients skewing this sort of, okay, sorry, let me try to go back a bit. How much are those patients sort of influencing these times? Right? And we need to dig a little bit more to separate out that effect. And you can see this pattern. This is, no matter how you look at it, along what dimension, you will see basically the same figure. If you look at imaging, if you look at surgery, if you look at labs, you will see more or less the same figure. And then we need to look at, okay, what patient characteristics are in these outliers that skew the length of stay and other indicators. So then another question that we're trying to examine is, okay, if length of stay is a poor indicator, which clinicians repeatedly tell us, what is? So we started looking at how these patients are distributed across the hospital, right? And this is a graph of, I think, complaints across clinical disciplines and across like medically responsible units. So thinking about it from a logistical or, a systems perspective, you would see ideally, in an ideal case, even from like, if you compare it to manufacturing, you shouldn't necessarily see such a dense matrix. You'd see a very sparse matrix where complaints are, for instance, this is in Swedish, so let me try to translate. So this is throat pain. should be constrained to, let's say, an ENT department. It shouldn't be spread across, I don't know, 10, 12 departments, right? Or even if it is, it shouldn't be spread across, maybe 1 or 2 is acceptable, not so many, for instance, right? But you see the spread across the entire hospital. And again, across diagnosis, across complaints, you will see the spread. Then they themselves, we went back to them and we asked, okay, can you flag, do you have any data on whether or not a patient ended up in the right place in the hospital? And somebody for a few years actually had collected the data. So this again, on the left are medical teams and medical units. So each sort of, so let's say if you have a ward, ENT ward, there'll be 3 teams and each team has a name just to make sure that they're responsible. And here are the ICD codes. So again, you should see big dots where one team or one department sees a lot of patients with one particular ICD code, right? Not so many teams handling one ICD code. This could be because of comorbidities, like if you have diabetes, you have most likely also have heart symptoms and so on. So more than one team should be responsible for your care, but you shouldn't really be seeing this spread. So then we went into, like I got the question, process mining. So we tried to extract that into some kind of event log, and we started looking at patterns, at processes. And this is the emergency department. It looks like a spaghetti diagram, as we call it. And if you expand this to the whole hospital, it looks much, much worse. Again, from an efficiency or a throughput standpoint, you should be seeing basically 1 or 2 or maybe 4 or 5 sort of paths between every step. You shouldn't really be seeing so many. This is with percentages. And again, as you can see, there are outliers. So this one path is 0.05% of the patient population. There are dominant paths with like 90% of the patients go along this one path. But again, some of the percentages are fairly absurd from an efficiency point of view. So we're trying to do this again, fairly simple data mining, process mining, performance graphs. This is the emergency department. This is with number of days. There is some waiting for 3 days with imaging with different departments involved and so on. We're trying to do bottleneck detection with like graph cuts, etc. Still progressing there. We want to do conformance checking, but there are no established clinical guidelines for a lot of them. So we're trying to collect that and do like conformance checking and see if that makes sense. And that's the summary, or rather summary of the entire hospital. From a sort of methodological point of view, this is, to me at least, this is fairly challenging. If anybody has ideas, I would love to hear it. We are now we've mapped out more or less the entire hospital, and we have a fairly good understanding of that. But to make improvements, we need to have, again, more robust evidence than this. So we started working on some specific sort of groups of patients, patient cohorts, and diagnosis. Right, so we're now working on urinary tract infections to see if we can make changes for people, for like a clinical workflow, who come in with urinary tract infections, right? But that is one of, I don't know how many diseases or diagnoses there are. So to do this on a case-by-case basis seems difficult, expensive, and too time-consuming. To model the entirety of the data set, we are kind of thinking about it and trying to figure it out. So that is kind of like one of the dilemma. How do we sort of, it's a large complex system. To draw like actionable insights from that sort of scale is hard. To translate sort of bottom up to actionable insights that are meaningful is time consuming and expensive. And yeah, that's where we are. So this is something also to contrast this to the first one, very simple sort of techniques, very difficult data set, very difficult sort of contextual problem. I'll quickly go through this one. I'd love to have some time for discussions. Then we are trying to tackle sort of the underlying data itself, right? So as you may all know, healthcare data is incredibly siloed, right? So data, even within a hospital like Karolinska, exists in different databases. They're not technically connected. It's hard to integrate them. There are standards, but not very well applied, and there are variations in relying on standards, etc., etc. So we're working on a graph-based approach to enable health data exchange and health data integration. So if you look at this figure on the right, you could have genomic data, you could have imaging data, proteomics, electronic health records, etc. Each one of those sort of sub-modalities comes with its own standard. So genomic is the HOP, imaging has DICOM, EHR has NOMED, LOINC, RX norm, etc., etc. Right? So the first step is we're trying to bind the individual data points to their descriptions in those ontologies, so that a data point or a set of data points becomes enriched with their descriptions. So once we establish that binding, we can then make use of already defined bindings across these ontologies to enable querying across all these modalities. Right. So these sort of meta ontology standards, so this meta language that binds these different sort of subdomains already exists, have been defined, or there are other standards that we can reuse. So we're trying to use large language models and graphs to basically take a data point and look for its descriptor in an ontology, establish that link, establish links across these domain ontologies to basically create a unified graph of medical data. If we are able to do that, then that will enable true multimodal sort of analysis, right? So if you have connected a feature in a patient's data to its relative sort of genetic component to a proteomics component, which now you have to do on a case-by-case basis, but if it's already there in the graph, you can actually query, you can actually search through the graph to do multimodal analysis. So we have already methods for doing that, to model it in a graph. We've already established uncertainty estimation methods. So what we can do is essentially say, okay, search through the graph, predict the links, predict the data within a certain confidence interval, all right? So if the confidence drops below a certain level, then this model won't give me the data. And this allows like fairly robust sort of search mechanisms across a very rich, very complex sort of graph. And you can think about this as a hypergraph, right? So you can say patient A has a diagnosis X, but patient A could have a diagnosis Y with, let's say, a certain confidence, right? So you can enable multiple relationships at different confidence intervals between two nodes in the graph. So this is what we are working on. Let's take this example, right? This is from Mimic 4. It's a gold standard open data set from the US. So these are lab items. So you can ignore the item ID. Free calcium, blood categories, blood clot. This is the material, this is the category, and so on. So if you look at the correct sort of description in an ontology, this is what you should bind it to, right? We can sort of Google this. It's tricky, but you have to do it. You have to know exactly. A human can basically figure this out, but you need an automated way of doing that. And that's what we're working on. So there is contextual data. There is sort of not so much contextual data, but you still need some of this. So this could exist anywhere. And We basically need to bind it, to annotate it and bind it to the right sort of descriptors in the ontologies. So that's what we're trying to do. We have some success with binding, terminology binding, and we're moving on to the next step, which is modeling all this data as graphs and sort of building neural networks on this data. So that's where we are. So those are the 3 projects. And yeah, some things that we think are true, not really sure. Health data is messy. It's complex. It's hard to model. Benchmarks say very, very little. So if you look at the discourse and see a model that says, I beat this benchmark, it's meaningless. Even model metrics don't really say very much, right? We know for sure that if you look at the colorectal cancer, small models are not very useful. Large language models, they're great for chat, but they don't really translate for decision support system. Foundation models, on the other hand, if you model it robustly for a particular diagnosis or for a particular setting, those are sort of easy, I wouldn't say easier, but they're probably the way to go. They can scale across contexts, across domains, and more importantly, those can actually be leveraged and procured and bought and developed into a system. No hospital is going to buy one model for one disease. They want one model for many diseases, right? So we need to start focusing on foundation models. One of the other things is, to be a bit critical about clinicians and the medical field in general. It's a very, very conservative domain for excellent reasons. But what we observe constantly is we're following the same sort of methodologies, and I'm being a bit provocative here. We're modeling, maybe AI and ML needs a bit of a mindset shift in what kind of methodologies we use to evaluate it, and etc. One thing is for the Mediverse project, we work with a lot of informaticians at various levels. And one thing they constantly ask is, okay, what formal guarantees can you give me that this is actually works and this data point actually is that data point? And we can't be deterministic when we're using AI and ML. So there needs to be a mindset shift in how we work with uncertainty in this domain. And that's pretty much it. That's where I will leave it. Any thoughts, any questions?
Thank you very much. It was really a wonderful lecture. I'm very happy that you pointed out that we have to be very careful in using these AI, ML in context, because context makes the entire difference. 2 things I want to mention, and we can talk about it later, you and I.
Yeah.
See, what we are dealing with in hospitals is that the workflows are not fixed, like in a manufacturing plant for a particular product. Each particular patient has his own workflow depending upon their condition. So it's constantly changing depending upon the population. That is one part. The other part, which is a bigger question, and I leave it, because after all, the cognitive of a hospital is distributed across many people. So you might be able to find out whether there are issues of semantic differences. For example, people read certain things and constantly they keep sending the same thing to the other department. So you may be able to measure for which tasks do they pass on the thing, and also ask the question, what is the information they are passing to each other? So you might be able to start finding that there is a mismatch in the semantic understanding of each other.
Absolutely.
Right?
Yeah,
so you could can talk about it later. There is a tool now called CapCollab from the Topos Institute where you can do hierarchical Petri nets. So you might be interested in what you're doing with that tool. I'll stop there.
So I'll just quickly respond. The first part, I don't fully agree. yes, every patient will have his own paths, but there needs to be a workflow by, let's say, condition, right? So not every patient, but somewhere in between.
There
And what
should
we
be a
see is that
workflow. They have to be conditional, and that is what makes it hard.
yeah, that we fully agree, but we don't even see that. The second part, I fully agree. Like for the urinary tract infection case that we're working on, like one thing that we know for sure is that, so the workflow should be, let's say the clinical pathway should be, if you come in with a suspected UTI, you should get antibiotics. If it doesn't work, if it doesn't go away after 3 days, then you get an X-ray, right? Now they do both at the same time. And that's because the staffing in the emergency department has shifted from having 10 different disciplines to one. So there used to be infectious disease specialists, cardiac surgeons, ortho people, etc., in the ED, but all of that has been kind of subsumed into one trauma specialization, who is kind of a generalist across all these domains, right? So the degree of evidence that that skill needs for a lot of these conditions has gone up. So he will order an X-ray and prescribe medicines, right? So it's this sort of both skill level and semantic kind of difference that is affecting the logistics of the hospital.
Yeah. We can talk more about it. See, how you configure the different departments make a big difference. So what the skill space of each department is. Yeah. We'll talk about it later.
Yeah.
Thanks.
No worries.
Yes, sir. Here, just I want to add that's why today in process mining, we are also, as you said, different workflows, about the different workflows, and exactly that BPMN, there are BPMN models which are showing the workflow at the first stage. We can demonstrate it with certain patronets, and because just like there can be so many order to cash, order to pay. Suppose for an e-commerce website, we have a different departments, different workflows. So same way, this work can be modeled through BPMN in future. Very interesting work from and presented very nicely. So I'll be more interested to go through it if you have a
please
link.
reach out.
Yes. The spaghetti model which you have designed. Yeah, there are so, because it shows the workflows. Yeah. So
so this is
very
inferred, not
alphabetically,
designed.
Jayanth has
So this
described everything.
Yeah. So
Yeah,
this is observed, not
exactly.
designed. And we're trying to use
Yes.
this is, I think, Python for PM or something tool. But yeah,
Pro-am.
you understand.
Yeah.
We are essentially following a process mining methodology.
Yes, exactly. Yeah, this is what the workflows are different for each department. We have a different workflows because it is very important, as sir has raised this question. So happy to, though I joined late, but very interesting talk. So, and it is nice that you are working in a in this domain. So nice interacting, and I think we should say, thanks Sudhir sir for this informative lecture today. Thank you.
Thank you.
So thanks, Jayanth. One question or clarification is the ontology that you talked about to bring more context sensitive this thing. What is the actual use case around which it is getting used?
Could you clarify?
Assuming you have this machine learning data, how does the ontology complement the context awareness aspect?
So this is not
or is it more to build your underlying model? What is the context of use?
No, so let me take a step back. If you want to exchange data between two hospitals, right? So you have to first figure out, let's say figure out the first row is what you want to send in an electronic package to the second hospital. Then you have to put it into what is now FHIR, which is a standard for sending healthcare data between two systems. You extract the data, you put it into the packet, you send it. The other hospital has to write code to receive that, to extract the fire packet and then hopefully in some form understand it. All right, but the only sort of context or semantics that is included in this packet is the column names, which as you can see is fairly meaningless. So even for just a simple sending one record for one patient between two systems, there's a lot of technology built, but there is no sort of semantic layer that is working very well. Even if all hospitals across continents or whatever implement FHIR, it still doesn't work very well. So what we want to do is we want to figure out in the first case, okay, what does this set mean? Value, value number, value unit, the reference range. If you just look at the value unit and the reference range, you will very quickly figure out what test this is, right? Because that is enough information and that's been modeled by experts and defined in an ontology. So if we can just say, look, this is a test for X, Y, and Z, here is the description. That already adds a rich layer of meaning so that the other hospital can infer it, both at a human level and at a sort of technical level. So that's one use case. The second use case is, basically to enable sort of this. How do we go from a person's electronic health records to, let's say, a gene mutation to a lab value, etc. Right now, all this has to happen on a patient cohort level. So you have to be able to tag patients to all of this information. And that is again, very time consuming, even if you can make it happen. Because no one hospital or no one database will have all of this data for 1 or even 100 patients. It is all distributed. So we need mechanisms to integrate all of this. That is not at a patient level, that also can handle different sort of levels of implementations of standards and descriptors and so on. So that's what we're trying to solve here.
Okay, thank you.
We can talk later about it. I have a solution process for you for this integration you're talking about. We can talk about it later.
Sure. Absolutely.
Any other questions from the audience? Anyone?
I've been thinking about this in different ways, as you know, in various ways healthcare can be transformed. And some of what you're talking about, the difficulty in transforming healthcare because of the complexities involved. And you also have these semantic differences. And you cannot force people to give up their own terminology. We'll have to figure out some ways of mapping them to each other because the plurality is inescapable. And the question is, how do we integrate it while leaving the plurality and increasing the semantic exchange, the meaningful semantic exchange?
Yep, exactly.
I like what you're doing by going from the data to say, okay, the data ranges tell me potentially what the problem is, what the test is. That's one way of inferencing, right? The other way of doing, I'll just give you an example very quickly. We are already past time. The US Coast Guard about 20 years ago tried to integrate their databases from different places. Those are all mainly relational and other databases. What they did was they went to the data dictionary of each one of those databases. And many of them had descriptions and ran natural language analysis on those descriptions as a way to construct the mappings between the different things. That trick might be useful to you if they have data dictionaries. Huh?
So we're not, we're doing that to a large extent, but I don't think we will get to the extent that we can get it, we will do it. But we're working, I think we're working with Google research on this. And we're trying to use LLMs to basically annotate everything. Right. So essentially, again, inferring from whatever source, whatever documents we can to annotate every column, every field, etc. So that again, building up from the data level to enable sort of more refined, more precise searches.
Thank you. Thank you very much for a wonderful lecture, and
thank you
I
for
hope
having me.
all of you enjoyed the lecture in terms of the complexity of the problem and the approaches. And thank you. You have a good evening, good afternoon, good morning, whatever fits you.
Thanks. Thank you for having me.
Thank you.
You want to announce the next lecture, Sudhir? Yeah, thanks.
Yeah, and the next lecture will come on, I think, 4th February or so. So we'll get back to you with details on that.
Thank you very much, everybody. Bye.
Thank you.
Thank you, Sudhir.
Thanks, John.
Bye.